All right, everyone, let's talk about something that can really put our skills to the test. Cardiogenic shock. We're talking about mortality rates still hovering around 40 to 50%, and that's with all the tools that we have.
Absolutely. And you know what's even more concerning? The landscape of cardiogenic shock is shifting.
Oh, yeah. How so?
We're seeing fewer cases tied to, like, the classic heart attack presentation and more that are stemming from things like decompensated heart failure or even post-op complications.
That's a good point. And that's probably a shift that, a lot of folks on the front lines might not fully realize.
Yeah.
So before we get into the weeds, let's make sure we're all on the same page. How do we define cardiogenic shock in today's world? What are we even talking about here?
Well, the simplest way to put it is that it's a state where the heart, for whatever reason, can't pump enough blood to keep the organs happy.
Right.
But you're right, it's not always a straightforward diagnosis. That's why we have tools like the SHARP criteria, which help us standardize the definition and really compare apples to apples in research and clinical trials.
Okay, so SHARP helps us nail down the diagnosis, but then how do we figure out just how bad things are? How do we wrap our heads around the different ways that cardiogenic shock can actually show up in our patients?
Well, that's where the SKAI classification comes in handy. It gives us this framework to stage the severity of cardiogenic shock from A to E. So think about it this way. A patient in stage A might just have some mild hypotension and maybe some subtle signs of organ underperfusion.
Okay, so that's helpful.
Right.
But then what about the opposite end of the spectrum? What might a stage E patient look like in the real world?
Oh, that's when we're talking about someone who's profoundly hypotensive.
Oh, wow.
Maybe even requiring multiple vasopressors just to maintain a blood pressure. They likely have significant organ dysfunction, and we're pulling out all the stops with mechanical support. This staging system helps us tailor our treatment strategies. Because obviously, you wouldn't approach a patient the same way you would a stage E.
That makes a ton of sense. All right, so we've got our definitions, we've got our staging down. Now, let's get into the physiology. Paint a picture for us. What's happening inside the body when this cascade starts?
All right. Imagine your patient's heart as a pump that's just not generating enough force to push blood out effectively. This could be because of a weakened heart muscle, a problem with the valves, or even something obstructing the outflow. The end result is the same, though. A drop in cardiac output.
And of course, the body doesn't just sit back and watch this happen, right?
Absolutely not. It tries to compensate. First thing it does is slam on the brakes in the blood vessels, causing them to constrict. This is like stepping on the gas pedal in a car with a failing engine. You're trying to rev things up, but you're not really going anywhere.
Right. So that's the vasoconstriction piece. What else is the body doing to try to fix this mess?
Well, on top of that, the kidneys kick into overdrive, holding onto every drop of fluid they can get. It's like trying to stuff more water into an already overfilled balloon. The pressure goes up, but you're not actually improving flow.
So in a way, the body's almost working against itself here, right? Like those compensatory mechanisms are well-intentioned, but they end up causing even more problems.
Exactly. And as if that wasn't enough, this whole crisis triggers this massive inflammatory response. The body releases all kinds of signaling molecules, cytokines, chemokines. They cause a whole cascade of damage.
Oh, yeah. So we're talking widespread inflammation. Organ dysfunction. It sounds like a recipe for disaster. So how do we make sense of all this hemodynamic mayhem? What tools do we have to really understand what's happening in these patients?
This is where our old friend, the pressure volume loop, comes into play.
Yes.
It's a visual representation of the heart's pumping cycle, and it can tell us so much about how much contractility is reduced and how that impacts stroke volume and filling pressures.
I'm picturing those PV loops from physiology class. They were always so helpful in visualizing those concepts. I imagine in cardiogenic shock, those loops are pretty distorted.
They absolutely are. And it's not just about the left ventricle either. We have to remember that the right ventricle often gets dragged into this mess, especially in those non-heart attack cases.
So right ventricular failure adds another layer of complexity. This is all starting to paint a pretty challenging clinical picture. But before we dive into the treatment side of things, I want to touch on the elephant in the room. It seems like we're seeing a shift in the root causes of cardiogenic shock.
You're right. For a long time, it was all about the acute MI, the classic heart attack picture. But now we're dealing with more cases stemming from things like de novo heart failure, post-cardiotomy shock, and even non-cardiac causes like sepsis or pulmonary embolism.
So it's not just about recognizing the signs and symptoms of cardiogenic shock, but also being aware of this broader range of potential causes.
Exactly. And here's the kicker. Our understanding and guidelines for managing these non-AMI cases are still catching up.
Wow.
So we're essentially dealing with a growing population of patients with a condition we're still learning how to best manage.
That's a crucial point. It highlights the importance of staying updated on the latest research and guidelines. So now that we've laid the groundwork, let's talk about what we can actually DO for these patients. How do we approach treatment in this evolving landscape of cardiogenic shock?
Well, the first rule of cardiogenic shock is that there's no one-size-fits-all approach. Every patient is different and treatment has to be tailored to the individual.
That makes sense.
Yeah.
But I imagine there's some core principles that guide our management, right?
Absolutely. The first thing we always want to do is identify and treat the underlying cause.
Right.
If we're dealing with an acute MI, then time is truly of the essence. We need to reperfuse that heart muscle as quickly as possible. That might mean going straight to the cath lab for angioplasty, or in some cases even considering emergent bypass surgery.
Right. The faster we can restore blood flow to that damaged heart muscle, the better the chances of recovery. I remember the SHOCK trial really drove that point home, showing a clear survival benefit with early revascularization. But what about those cases where it's not a blocked coronary artery? What do we do when the cause is something like heart failure or a valvular problem?
That's where things get a bit more nuanced. In those cases, we might be looking at things like optimizing medical therapy, making sure they're on the right doses of diuretics, ACE inhibitors, beta blockers, whatever their specific situation calls for. If the heart failure is severe, we might even need to consider temporary mechanical circulatory support like an Impella or tandem heart to give the heart a chance to rest and recover.
Okay, so address the root cause first and foremost. Then what? What are the mainstays of medical therapy for these patients?
Well, we're often reaching for our trusty vasopressors and inotropes. These are the medications that help us stabilize blood pressure, improve heart contractility, and ultimately get those vital organs the oxygen they desperately need.
But I imagine finding the right balance is tricky. Too much squeeze on those blood vessels, and you could actually end up doing more harm than good.
You're absolutely right. It's a delicate dance, and the choice of medications and their dosages really depends on the individual patient's hemodynamics and overall clinical picture. It's not a cookie-cutter approach.
So we're titrating those meds carefully based on what the patient's telling us, both clinically and hemodynamically. What about things like antithrombotic therapy? Preventing clots seems crucial in these folks, but the bleeding risk must be through the roof.
You hit the nail on the head. It's another one of those balancing acts that we have to manage. We need to weigh the benefits of preventing clots against the very real risk of causing a major bleed. Patient selection is key here, and we need to carefully assess each individual's risk factors. Sometimes the risk is just too high, and we have to hold back on the anticoagulation.
Makes sense. Now let's talk about the heavy artillery, the mechanical circulatory support devices. There's a whole alphabet soup of options out there. IABPs, Impella, tandem heart, VA ECMO. How do we decide when and which one to use?
It's definitely a complex decision-making process. First and foremost, we need to make sure the patient meets the criteria for mechanical support. We're looking at things like their level of hemodynamic instability, the severity of organ dysfunction, and their overall prognosis. Then we have to consider which device is most appropriate for their specific situation.
So walk us through some of the main players. Let's start with the old workhorse, the IABP. It seems like it's fallen out of favor a bit in recent years.
That's true. Large trials like IABP SHOC2 showed that routinely using IABPs in AMI-related cardiogenic shock doesn't really move the needle on survival. It's still a useful tool in certain situations, like bridging to other therapies or managing specific complications, but it's no longer the go-to for every patient.
So if not IUBP, what's taking center stage these days?
Well, devices like Impella and Tandem Heart are gaining a lot of traction. They offer more direct support than an IABP, actually pulling blood from the ventricle and pushing it out into the aorta.
So they're essentially doing some of the heart's work for it. But I imagine there are downsides to these devices as well, right?
Of course. Anytime you introduce something foreign into the body, there's a risk of complications. We're talking about things like bleeding, infection, and even device malfunction. Plus, these devices aren't exactly cheap, so it's all about weighing the potential benefits against the risks and costs.
And I imagine that decision gets even more complicated when we're talking about VA ECMO, which essentially takes over the entire circulatory system.
VA ECMO is definitely the big gun, and we reserve it for the most critically ill patients. But even then, the evidence isn't always clear-cut. The ECLS-SHOC trial, for example, didn't show a survival benefit in AMI-related cardiogenic shock when compared to conventional treatment.
So VA ECMO is a powerful tool, but it's not a magic bullet. And it sounds like even with all these options at our disposal, deciding which device, if any, is right for a particular patient is a complex and nuanced decision.
Absolutely. It requires a multidisciplinary approach, close collaboration with our cardiology colleagues, and careful consideration of the individual patient's needs and goals of care. And the field is constantly evolving, so it's crucial to stay up to date on the latest research and guidelines.
Speaking of evolving, I want to shift gears a bit and talk about what's on the horizon for cardiogenic shock treatment. What does the future hold for these patients? What are some of the exciting developments that have you, shall we say, geeking out a little?
Oh, where do I even begin? There's so much happening in the world of cardiogenic shock research right now. It's a really exciting time to be in this field. We're seeing a huge push toward personalized medicine, using biomarkers and genetic information to tailor treatment to the individual patient.
That's fascinating. It's like taking precision medicine to the next level. So instead of a one-size-fits-all approach, we're trying to figure out which therapy is most likely to work for each specific patient.
Exactly. And that goes hand in hand with the development of novel pharmacological agents. We're talking about drugs that target specific pathways involved in the pathophysiology of cardiogenic shock. Things like ketone esters, which provide an alternative energy source for the heart, or deep T3 inhibitors, which modulate the inflammatory response. These are just a couple of examples, but there's a whole pipeline of promising drugs in development.
So we're talking about potentially boosting the heart's energy supply, calming down that runaway inflammation, and maybe even regenerating damaged heart muscle. It sounds like science fiction.
It does, but the early research is very encouraging. And then there's the world of artificial intelligence and big data. We're using these powerful tools to analyze massive data sets and identify patterns that could help us predict which patients are at highest risk of developing cardiogenic shock and tailor our interventions accordingly.
So it's like having a crystal ball that helps us identify those at-risk patients before they even walk through the door.
Exactly. And let's not forget about the potential of gene therapy and stem cell therapy. These are still early days, but the possibilities are truly mind-blowing. Imagine being able to actually repair a damaged heart at the cellular level.
It is incredible to think about what might be possible in the future. But I want to bring us back to the present for a moment. With all these advancements on the horizon, what are some key takeaways you want our listeners to walk away with today? What are those practical pearls that they can apply to their practice right now?
Well, I think the most important thing to remember is that the landscape of cardiogenic shock is changing. We need to be aware of this broader range of potential causes and be prepared to adapt our management strategies accordingly.
So we're not just thinking about the classic heart attack presentation anymore. We're considering things like heart failure, valvular disease, and even non-cardiac causes.
Absolutely. And we need to stay on top of the latest research and guidelines. The field is moving quickly, and what we thought was true yesterday might be outdated tomorrow.
So keep learning, keep questioning, and keep pushing the boundaries. And most importantly, don't be afraid to reach out to your colleagues for help. Managing these patients is a team sport.
Well said. And I want to leave our listeners with one final thought to ponder. With all these advancements in personalized medicine and targeted therapies, how can we as a medical community ensure that these innovations are accessible to all patients, regardless of their background or socioeconomic status? That's the challenge we need to tackle together.
That's a powerful message and one that I wholeheartedly agree with. Healthcare should be a right, not a privilege. And we have a responsibility to advocate for our patients and make sure that everyone has access to the best possible care. It is incredible to think about what might be possible in the future. But I want to bring us back to the present for a moment. With all these advancements on the horizon, what are some key takeaways you want our listeners to walk away with today? What are those practical pearls that they can apply to their practice right now?
Well, I think the most important thing to remember is that early recognition is key.
So we're talking about being really attuned to those subtle signs and symptoms, not just waiting for the full-blown picture of hypotension and end organ damage to develop.
Exactly. We need to be thinking about cardiogenic shock in any patient who presents with signs of poor perfusion, even if their blood pressure is still relatively stable.
So those early clues like altered mental status, cool extremities, maybe a drop in urine output, those could be red flags that something more serious is brewing.
Absolutely. And once we have that suspicion, we need to act fast. That means getting appropriate monitoring in place. Not just blood pressure, but things like central venous pressure, pulmonary artery pressures, and even continuous cardiac output monitoring if available.
So we're talking about really getting a handle on what's happening hemodynamically. Because like we talked about earlier, managing these patients is all about understanding those subtle nuances of preload, afterload, and contractility.
Exactly. And once we have that hemodynamic picture, we can start tailoring our interventions. Sometimes it's as simple as fluid resuscitation or starting a low-dose intratrope. Other times it might require more aggressive measures like mechanical circulatory support.
Right, and those decisions are never easy. It's always a balancing act, weighing the potential benefits against the risks of each intervention.
Absolutely. And that's why it's so important to have a good understanding of the different mechanical support options available and when it's appropriate to use them.
So folks, brush up on your IABPs, your Impellas, your VA ECMO. Knowing the ins and outs of these devices could be the difference between life and death for your patient. Any other practical tips you want to leave our listeners with?
I think it's important to remember that managing cardiogenic shock is a team effort. We need to be communicating effectively with our colleagues. Cardiology, critical care, even the pharmacists. Everyone has a role to play in optimizing care for these patients.
That's a great point. It's not a solo mission. We need to be working together, sharing information, and making decisions collaboratively.
Exactly. And one final thought. Don't forget about the patient and their family. This is a scary and overwhelming experience for them, and they need our support and compassion just as much as they need our medical expertise.
Couldn't agree more. So take a moment to explain what's happening, answer their questions, and offer reassurance. Sometimes a little bit of human connection can go a long way.
Well said. And for all our listeners out there on the front lines battling cardiogenic shock day in and day out, I just want to say thank you. Your work is incredibly challenging, but also incredibly important. Never underestimate the impact you have on the lives of these patients and their families.
Absolutely. You are the heroes in this fight, and we salute you. And remember, we've included a comprehensive list of resources in the show notes for those who want to delve deeper into specific aspects of cardiogenic shock management. We've got articles from Circulation, the Journal of the American College of Cardiology, and the European Heart Journal, to name a few.
And don't hesitate to reach out to your colleagues or mentors for guidance. We're all in this together, learning and growing as we go.
That's right. Keep those brains engaged, keep those hearts passionate, and keep making a difference. Until next time, stay curious and stay compassionate. Disclaimer and bibliography in the description.